Can you start the recording? So just a few things when we are not sharing slides, would everyone please be sure their screens are on gallery view so that we can see everyone, and also of course have your camera on. I'm Rhea Markowitz, and I'm from the Georgia Cancer Center, and I'm part of the hub team for teledermatology. Dr. Doug Patton and I will be serving as co-facilitators of this TeleECHO session today. So I want to welcome and introduce teledermatology clinic healthcare providers. Brenda, could you take the slide off? And if all the slides off. Stop sharing. And so as I welcome various people, if you wouldn't mind giving a wave. So I want to welcome our teledermatology healthcare providers. So is Dr. Sam Whaling here? Sam, are you here today? Lori Hutchins from Mount Vernon. Aisha McFarland from EGHC Soperton. I saw her name up there.
Yeah, can you speak closer to the microphone?
Okay, Sabrina Watkins, I think she's still on maternity leave. Stephanie Cawthorn and Carolyn Jones from EGHC Baxley, are you here? I see your names. Or I see Carolyn's name. Okay, and there, yep, okay. Floyd Soriano and Phyllis Solomon from EGHC Metter, are you here? Billy Stout from Sylvania, I see her. And John Ferrier from Wadley. So welcome to all of you. I want to welcome our residents from Department of Family Medicine. The conference room there, down there, okay. And is Dr. Cortez here? I don't think he is. And then we have our dermatology team. So there's Dr. Davis. Hello. Dr. Rabinowitz, Dr. Buchanan. And we may have some derm residents and medical students out there. And then we have members of our telederm team here at the hub. So we have Brenda Santiano, and she's running the controls for the first time today. So, so that's really great. Glad to have her on board. We have Kenza Mamouni over behind me and Marisol Miranda, and they're both at the controls, and Kenza does the CME and all of that. And then we have our two medical students. You've met Mackenzie Maloney before, and we have Gabby Duquesne, another medical student who are here at the hub. And Mackenzie got some of us some goodies here at the hub room, so that's an incentive to come here. So let's see. Dr. Patton has already asked that people put your name and email address and affiliation, clinic, whatever, in the chat box. So I think everyone's up to speed on that. And so now we'll go over today's agenda. So Brenda, if you can share. So here we are with today's agenda, a little bit of introduction as usual. Dr. Kendall Buchanan will present our didactic part today. The topic is benign and fine. Love Kendall's titles. Characteristic features of common benign neoplasms. And then we'll have two case presentations. The first one will be by Dr. Etsu Ajebo, one of the derm residents. And then we will have a presentation by Sally Jung, one of fourth year medical students. And following discussion, we'll have a wrap up and announcements about the next session. So let's see. I think now I can introduce Dr. Doug Patton, who will take over the session. As I have said 6 times before, Dr. Patton is the Dean of the Southwest Georgia Regional Campus for the Medical College of Georgia and has spent most of his career as a rural physician. Doug, take it away.
Thank you, Rhea. It is good to be back together again with everyone. I hope everyone had a good holiday over Labor Day. And we're going to go through these slides again, and we'll go through them faster and faster each time. But we want to remind everybody what Project ECHO is, the Extension for Community Healthcare Outcomes, and the tagline is moving knowledge instead of people. Next slide, please. So these sessions are designed to improve the knowledge of all of the participants, in this case, particularly focusing on teledermoscopy and teledermatology at your level, at the level of local practice, and to use these distance learning techniques to teach each other about how to better provide for dermatologic care and identify lesions as suspicious or not suspicious across the state of Georgia, giving better access to rural Georgians. Next slide, please. So these sessions are recorded, as we've mentioned 1,000 times, but you're consenting to being recorded by participating. And we do want to remind everyone not to share PHI in the discussions. These are not teleconsultations, and PHI should be protected. There will be information in the final slide and in the chat about getting credit for CME and CNE. And of course, you can always email questions or concerns to teledermatology@augusta.edu. Next slide, please. So we do collect data, beginning with registration all the way through participation, answers of questions, chat comments, etc. And this data helps us to inform current offerings as well as future offerings. And we use them for quality assurance and research purposes, mainly to inform new initiatives and how we can better serve the needs of the participants. Next slide, please. So the general Zoom reminders, mute yourself when you're not speaking, unmute when you do, type into the chat, raise your hand if you have a question that's important, particularly during the question and answer sessions, which will be defined and follow each presentation. Remember to speak up, introduce yourself, tell us who you are, where you work, which clinic you're at. And if possible, if your technology will allow you, if your broadband capacity allows it, please leave your cameras on all the time so we can see the faces in the gallery view. You can always email other technical problems immediately to kmamooney@augusta.edu during the presentation if necessary, or into the chat. We'll be monitoring that as well. Let's see, any questions or concerns from anyone in the audience? I don't have the chat open, so I can't see. Looks like we're still getting registrants. That's good.
Yes, and I will welcome several of our clinic people, teledermatology clinic PCPs have logged on since I welcome you all. So welcome again.
That's good. And we're glad to have you. Even if you're a few minutes late, we know everybody's running busy practices and it's hard to just drop everything and run. So thank you for joining us. Now it's my pleasure to introduce again Dr. Kendall Buchanan as a featured speaker. She practices dermatology over in AU's Care Center for Dermatology in Aiken, South Carolina. And today's talk is, as Rhea shared, benign and fine, characteristic features of common benign neoplasm. This will be about a 20-minute presentation. We'll stop as we get close to the end of that and leave a few minutes for questions at the end of that time. Dr. Buchanan, are you ready to share your screen? There you go.
Okay. All right, guys. We'll go ahead and get started. Okay, so benign and fine. So today, as you guys recall, we've already talked about benign nevi. So today we're going to focus on benign non-melanocytic neoplasms. So if you recall our two-step algorithm, the first question that we ask ourselves is it melanocytic or non-melanocytic? So today we're going to focus on the right half. So we'll talk through lentigos, dermatofibromas like implantocyte keratosis. Keep in mind, you've seen some of these things before. So some of this will be a little bit of a refresher. So we're going to start with seborrheic keratosis. And so these have several different names, birthday presents, wisdom spots, old age spots, barnacles. And then I love that Dr. Rabinovitz says this, welcome to the 50s club. So if you're talking to your patients, the one I would say, do not say is old age spots. If they say it, that's okay, but it never comes from my mouth. I always say birthday presents or wisdom spots. Okay. So these are benign. As you can see on this patient, they often follow the folds, the lines of the skin, so they can kind of fan out, especially if they're on the back. They're often raised or what we call stuck on, and they're warty or waxy. They're extremely common and they're found in all skin types, though they can present differently in different skin types. They occur on sun-exposed and non-sun-exposed areas, and typically less common on areas that are double clothed, like the buttocks. And they're only found in hair-bearing sites, so not on the palms and the soles or on the mucosa. Some variants are dermatosis papulosa nigra and stucco keratosis. So this is a patient I saw last week. She presented with these sort of waxy brown black papules on her cheeks. And then another variant is seen often in Caucasian individuals on the lower legs, kind of this chalky white stuck on papules. So these are benign. And so on dermoscopy, we see several different features: milia-like cysts, comedo-like openings, fissures or sulci, fingerprint-like structures, moth-eaten borders, sharp demarcation, gyri or ridges, and then hairpin vessels with a halo. And so we'll go through each of those. I did want to briefly kind of go over a case that Dr. Whaling sent me last week. I thought this was a good example. So you can see this sort of stuck on brown papule on this patient's cheek. And then on dermoscopy, we see sharp borders. We see comedo-like openings, vessels with a halo, and then you can see fissures and ridges. So this was a great example of a seborrheic keratosis that Dr. Whaling sent me. And so milia-like cysts, they're often white or yellow in color. They're round, and they're best seen with non-polarized dermoscopy. And they are highly suggestive of a benign keratosis. And you can see here these little cysts that are up in the epidermis. Comedo-like openings are similar. They're keratin-filled structures. They can be circular or elongated, and it's essentially a collection of keratin, and they are very common in benign keratosis. Fissures or sulci, I put this picture of a brain here because I think that's kind of the best way to think about these. The fissures are these sort of deeper invaginations, and they're linear keratin-filled structures. And then the ridges, it's easy to remember, the ridges are raised and they're sort of projected out. And it's essentially a descriptive term for multiple thick lines with invaginations. So these are all common to seborrheic keratosis. Another thing that can sometimes be lost when you're evaluating lesions and you're wondering if it's melanocytic or non-melanocytic, seborrheic keratosis tend to have very sharp, crisp borders, and they end abruptly. And you can also have moth-eaten or scalloped borders. These are probably more so seen with solar lentigos, but you can see these in both, and both of these are benign. Hairpin vessels with halo. So these vessels are looped. They often resemble that of a hairpin. And then you can usually see a white halo around the blood vessels. You can see these in benign keratosis. You can also see these more commonly when the keratosis are somewhat inflamed or irritated. And these are just further examples that Dr. Rabinovitz provided. And you can see these vessels in other non-melanocytic neoplasms, such as like squamous cell carcinoma and keratoacanthoma. So they're not specific to seborrheic keratosis, and you can see them with other keratinizing tumors. So solar lentigo, these are typically flat. They have well-defined borders. They're multiple, very common on sun-exposed skin. So we see these a lot on the face, the dorsal hands. You can even see them on the lips. And they're pretty common after age 60, especially in Caucasians. What we see on pathology is essentially two different patterns. You can see what's called a dirty sock pattern. So the tips of the reedy ridges are sort of have this hyperpigmented area. You can also see just a flattened epidermis. And these different patterns are what is responsible for the different dermoscopy features that we see. So you can see increased melanocytes in seborrheic keratosis. You can also see increased melanin. But in these lesions, you typically won't see any melanocytic atypia, nesting of melanocytes, or keratinocyte atypia. And the main structures that we see with lentigos are the fingerprint-like structures, moth-eaten borders, and sharp demarcation. You can also see these light brown structureless areas as well. So fingerprint, these are short and fine lines that are slightly interrupted. They can be slightly curved as well, and they kind of correspond to the reedy ridge elongation with pigmentation of keratinocytes. Again, the moth-eaten are scalloped borders, and these also end abruptly. Another example of well-defined sharp borders, and you can see the lesion is relatively structureless as well. And so these benign lesions lack melanoma-specific features and patterns. Lichen planus-like keratosis, this one's a little bit more challenging. We often call this the great masquerader. It's more challenging typically when it's seen on the face, because in your differential should be a lentigo maligna or melanoma in situ. And this is an example of a dermoscope photo of LPLK. And you can see features of a lentigo with the fingerprinting, and then you can also see this diffuse kind of gray dots granules. And so typically these can be gray, or they can also be pink, and they can be a thin plaque or a patch. They can have crust or scale. We think of these as a solar lentigo or seborrheic keratosis undergoing regression. So this happens at different stages. So that's why you can see features of a solar lentigo or features of a seborrheic keratosis. And if you see that in combination with the gray dots granules, then your diagnosis of lichen planus-like keratosis is more likely. These are more common in Caucasians, females, and on sun-damaged skin. Clinically in dermoscopy, as I mentioned, these can mimic melanoma in situ. And this is just an example of, we often say things like coarse granularity. And so I think about this in terms of peppering, and we'll talk about that further in a minute. So this was an 80-year-old female who had a new lesion on her right arm. This was back when I considered myself a novice, and I took this photo and I thought it was the coolest thing ever. Didn't really know what it was at the time, so biopsied it. And indeed, we see sharp borders, and we see this diffuse and coarse granularity. So this was indeed a lichen planus-like keratosis, also called benign lichenoid keratosis. But as you can see, again, very sharp and abrupt cutoff. So in general, they're actually more frequently non-pigmented, located in the trunk, and on a background of chronic sun damage. Your differential includes actinic keratosis, BCC, SCC, melanoma, a benign keratosis or lentigo, and atypical melanocytic proliferation. So as you can see in this photo, they are called the great masquerader for a reason. And so we often describe pigmented LPLKs as having peppering or coarse granularity. And as I mentioned, features of a benign keratosis or a solar lentigo. So, and usually whenever you think about LPLK, especially if it's pigmented, if it's diffuse coarse granularity without any other melanoma specific features, you can be reassured that it's benign. And then here's another example. You have your coarse granularity or peppering. You have your comedo-like openings and your ridgers and fissures. So this was a combined an LPLK with features of seborrheic keratosis. This was a patient of mine. She came in with this isolated pigmented lesion on the right jawline. Actually, on further exam, looking at it more closely, it actually has a gray appearance, which you can see with an LPLK. So the differential included melanoma on sun-damaged skin. So I was concerned, but on dermoscopy, you see this beautiful example of just coarse granularity, what we call peppering, which is the collection of gray dots granules. And you see it's diffused throughout. It's very clean appearing. There's no other melanoma specific features, no angulated line formation, pigmentation around the hair follicles, that sort of thing. And we haven't talked about the differential for facial lesions yet, but we will at a later date. And so non-pigmented LPLKs, they can have other features. I think these can be extremely challenging. Most of these you're probably going to biopsy to rule out a BCC or a squamous cell carcinoma. Dermatofibromas, we've seen this before. Oops, let me go back. Many times. Usually these are firm indurated papules or nodules, very common in females, very common on the lower legs. They often occur in response to trauma. So as Dr. Diamond had showed us before, these actually occasionally dimple when pinched, and it can be a very helpful clue because these can have different patterns on dermoscopy. The most common pattern is the network with central white blotch, but you can also see a network with ring-like globules, shiny white streaks, and a pink hue. There's many other patterns. And so this peripheral network is caused by this follicular induction. So you can see the kind of pigmentation at the tips of the rete. And then the white central scar-like area is due to the dense collagen bundles and fibrosis. And this is just another example. You see these ring-like globules with central scar-like area. Another example, you have a more pink hue and you have some shiny white lines. And this is best seen with polarized light. And this is an example in a patient with a darker skin type. So you still have that delicate peripheral network and shiny white lines with central kind of scarred area. And so this is a dermatofibroma. These can also be more pink and have vascular structures. Not uncommon to see dotted vessels that are diffused throughout, again with a central scar-like area. And there's multiple different patterns like we talked about, the most common being pattern 2, which is the peripheral network and central white scar-like area. So you can start to kind of pick up on these. Again, always palpate, always kind of press to see if that dimple sign is present. Next, we'll talk about angiomas. So these are isolated red papules. Usually everyone has these, especially Caucasians. But they are common in all skin types and they're equal in males and females, and they're typically asymptomatic, but they can bleed if traumatized. On dermoscopy, angiokeratomas, they can present as similar to cherry angiomas. These often are more hyperkeratotic, and so they often have a sort of crusted surface. They can be solitary or grouped. So in grouped cases, we think about angiomas of Fordyce, which can be on the scrotum or labia. And you can also see things like angiokeratoma corporis diffusum, which is seen in Fabry's disease. And so for dermoscopy criteria, cherry angiomas typically have red clods or what we call lacunae, and they also have fibrous septae, which are the white lines. Angiokeratomas look very similar. They have a red, blue, or black lacunae, a whitish veil, and again, hyperkeratosis. So this is an example courtesy of Dr. Rabinovitz, where you can see the red clods and the fibrous septae. And then an angiokeratoma, multiple kind of purple clods or black lacunae, as you can see here, different colors for the lacunae. These are other features published by Dr. Zabalos in 2007, so they can have different patterns. The lacunae are simply dilated vascular spaces, but they can be thrombosed, so they can typically appear darker at times. You can also see a whitish veil, which is essentially a reflection of the hyperkeratosis and acanthosis. And these are some different examples here. The dark lacunae are highly specific for angiokeratomas. There's different patterns. We won't go into detail about these, but pattern 1 is the most common, where you see the dark lacunae and the whitish veil, and that has a sensitivity of 84% and a specificity of 99.1%. Sebaceous hyperplasia, also an extremely common lesion. These usually present with multiple, often found in Caucasians, usually later on in life, and they're very common on the face. The reason they're important to identify with dermoscopy is because they can be confused with a basal cell carcinoma. This is an example of what a sebaceous hyperplasia looks like on path. You see these multiple cleared out cells with this sort of basaloid rim. And these are what we call normal sebaceous glands in a little higher power. So on dermoscopy, we see these white yellow globules. Some people will call them popcorn-like. And you can see these crown vessels that do not cross the midline. And that's very important. Usually these are less or out of focus, less sharp as compared to a basal cell. And usually you'll see a central dell as well. Here are just some more examples: white yellow globules, crown vessels that do not cross the midline. So think about this, the vessels being arranged in a crown-like pattern. Clear cell acanthoma. These are variants or thought to be variants of seborrheic keratosis. They have distinct histopathology and dermoscopy features. So they're usually solitary, often lower legs, and peak incidence is around 60 years old. They're typically asymptomatic, but they can bleed if scale is removed. Some people refer to these as sort of like an isolated plaque of psoriasis because it has very similar features to psoriasis on pathology. And this is what, if you've never had a vanilla wafer, I would encourage you to eat one. This is that wafer-like scale, so very, very fine around the periphery. And this is an example of pathology. You have this epidermal or psoriasiform hyperplasia. You have these cells that are cleared out due to glycogen accumulation. And there's an abrupt transition between normal epidermis and the epidermis seen in the lesion. Other features are pinpoint red dots, globular red dots, and these typically have this linear or serpiginous string of pearls pattern on dermoscopy. So as you recall, we can see dotted vessels in squamous cell carcinoma, in psoriasis, porokeratosis, lots of other lesions. But the clue for clear cell acanthoma is how these vessels are arranged. And again, we call that the string of pearls. And these are just some more examples here. And as you can see, these are other examples that have these vessels as dots or coiled vessels. But again, with a clear cell acanthoma, you really want to look at the arrangement. This was a patient I saw a couple of weeks ago. I sent this photo to Dr. Rabinovitz, but 71-year-old female, she had a new lesion on her right temple and she was concerned about it. As you can see on dermoscopy, it has very sharp borders, wafer-like scale, and then vessels as dots with string of pearls pattern. So I think this is a clear cell acanthoma. I didn't biopsy it. I reassured her that it was benign, and she's coming back to see me in a couple months. So, but like I said, usually these are located on the lower legs. So that's all for today. I hope that that was helpful. These are my references here. And then next time we will do our lecture on basal cell carcinoma. Thank you.
Thank you, Dr. Buchanan. That was super helpful. I'm trying to add new acronyms to my list on, and seems like every time we meet, I get a new one. So LPLK may be my new acronym for the day.
I love it.
It's like keratosis. So
Yes.
do we have questions or comments from the gallery? I don't see anything new in the chat. Want to give a special acknowledgement to Dr. Whaling for sending in dermoscopic evaluation for consultation that made its way into the presentation. So we certainly want to encourage each of you who are out there with the dermatoscopes in your hand, with the mole scopes, to be able to take advantage of that. We've gotten some feedback that there may be opportunities for us to work on the process of obtaining the consults and make that easier for each of you. And so if you have questions about that, or if you have comments or needs about the opportunity to get some booster education on how to actually use the devices, then please let us know, because it's one of those things, when you introduce a new technology, it causes some concerns, and when you introduce a new process into your already busy clinic schedules, that can create issues too. So be sure and keep us engaged in that aspect of this as well. Any other comments or questions for Dr. Buchanan at this point?
I'm going to be proud of my wisdom spots.
There you go. Dr. Whalen.
I do have a question for Dr. Buchanan. One, thanks for including that picture. That was great to see one of my patients' cases up there. But trying to think of the name now. Seborrheic keratosis. Do those ever become malignant, or is it just they're always benign?
They are benign, but what you can see is collision lesions. So I have just recently, a couple weeks ago, had a collision of a benign of a seborrheic keratosis and a basal cell skin cancer. So, you still have to evaluate them, but there's no malignant potential with a seborrheic keratosis in itself. It's usually the collision lesions that you have to watch out for.
Great question. Well, let's keep it moving, and let's move along to Dr. Etsub Ajibo, who's a derm resident, and he's going to present our first case study today. So, Dr. Ajibo, are you ready to present?
Yes, thank you. I'm going to try to share my screen. If not, I'm sure.
There you go.
You can see it, and that's nice.
Yeah.
Okay. Wonderful. Okay. So a couple of weeks ago, we saw a 56-year-old Caucasian woman with past medical history of basal cell skin cancer of left cheek, who came in with complaint of a lesion on her right cheek that started about 6 months ago. So you can see the lesion right here on her right cheek. So we did dermoscopy, and we saw this. So the question is this melanocytic or non-melanocytic lesion? So you can see over here, serpentine basals, and you can see this white shiny area. So those are features of basal cell skin cancer, which is non-melanocytic. So other things you could see with basal cells are leaf-like areas, large blue-gray ovoid nests, multiple blue-gray non-aggregator globules, or you could see spoke wheel-like structures, or shiny white areas, as you can see up here, or even ulceration. So we did a biopsy, and the biopsy came back as infiltrative and morphiform BCC, and she was treated with Mohs surgery. So what are some of the other dermoscopic features you can see with basal cells? I'm sure Dr. Buchanan is going to go over that at next session, but for now, basal cell could show, like, it could be non-pigmented, or it could be pigmented. With pigmented ones, you can see large blue gray ovoid nest. We can see an example in the next slides. and arborizing telangiectasias, multiple blue-gray globules, ulceration, leaf-like structures, spoke wheel-like structures, shiny white blotches and strands. So you can see up here an example of maple leaf-like structures. So these areas are defined as discrete bulbous extensions connected at a base area, forming a leaf-like pattern. They're usually brown or gray-blue in color. So since the color is darker, it comes out as pigmented basal cell. So up here you can see the arborizing telangiectasias. So this consists of multiple branching blood vessels in a tree-like pattern. The base of the vessel is larger and the branches of the vessels become smaller in diameter. As you can see, it tapers down as you go away from the base. And the vessels tend to be bright red and they are sharply in focus, as you can see here. So up here you can see blue-gray ovoid nest, courtesy to Dr. Rabinowitz. So these blue-gray ovoid nests, they are confluent or nearly confluent, and they are well circumscribed, pigmented ovoid and elongated areas. They may not be connected to the pigmented tumor body. So you can see this big nests. So these are blue-gray ovoid nests. Then you can see up here spoke wheel-like structures. So these are radial projections that are surrounding a central darker point. The projections have a tan, blue, or gray color, and the central point or hub is usually dark brown, blue, or black. And up here you can see the blue-gray dots and globules. These are well-defined round or oval structures. They are a little larger than dot, but smaller than ovoid nests. They are not aggregated. When you see melanocytic lesions, usually these are aggregated, but in basal cell skin cancer, they are like a buckshot scatter. They are more of scattered around, non-aggregated. Then you may also see shiny white blotches and strands. You can only see this usually in polarized dermoscopy. And you can see white patches or blotches and linear white areas called strands with this. And then the last structure you can see is ulceration. So this consists of shallow erosions that may be covered with congealed blood. They can also have an orange hue if it is covered with serous crust. You can see the orange hue right here. So why did I choose this case? I chose it because basal cell skin cancer is one of the most common skin cancer, and you are likely to see it in your clinic. And also this case highlights common dermoscopic features of basal cell skin cancer. So questions for the ECHO team: how often should a patient with history of basal cell skin cancer be monitored? And that's it. Thank you.
Thank you very much, Dr. Ajibow. Leave that question slide up for just a second, if you would, please. Because we'd like that to be the yes. Who would like to offer a thought from the field about how often you monitor someone who's had a history of basal cell carcinoma? Does anybody from one of the clinics have a thought or a suggestion on what your current practice is? Don't be shy. All right, well then let's turn to our maybe one of our derm residents or medical students who's sitting in with the derm team today. Anyone have a comment about what the recommendation is, or what kind of guidelines we would apply to a patient about being monitored once they've got a history of basal cell skin cancer?
I think every 4 to 6 months. It also depends on sort of how much, person's history of chronic UV radiation. You can usually kind of tell based on the number of basal cells or the number of squamous cells or melanomas they've had. Some patients are just going to be a little bit more high risk. If patient has a superficial basal cell, you could probably stretch it out to 6 months. But if you've biopsied a more infiltrative, morphiiform, something with a little bit more of a malignant pattern, or worrisome pattern, you would probably want to see them back a little bit more frequently, like maybe even 3 months, kind of depending on their other risk factors.
Sure. So numbers of lesions, history of ultraviolet exposure, numbers of other skin lesions that they've got, just that could be at risk. Is it fair to assume that most basal cell cancers would ultimately ulcerate if they are left untreated? Is that fair, or am I completely wrong?
Not necessarily. I mean, you can have superficial basal cells that are just sort of pink and scaly. They usually don't tend to ulcerate. More nodular basal cells, if left untreated, will often ulcerate, however.
Okay, perfect. Thanks for clarifying that. Any questions or comments from anyone else before we move along to our medical student presentation? I don't see anything new in the chat. All right. Well, then, thank you very much for the commentary, Dr. Buchanan. Dr. Ajibo, thank you again for the presentation. Well, now it's time for Sally Jung, who's a fourth-year medical student, and she's going to present our second case. Sally, are you ready?
I am. Let me share my screen real quick.
We got you. Thank you.
And can you see my presentation? Okay,
We
perfect.
can.
I'm Sally. I'm a fourth-year medical student at the Medical College of Georgia, and today I'll be doing a case report presentation with help from Dr. Buchanan and Dr. Rabinovitz. So we'll start with our case presentation. We have an 83-year-old male. He has a negative history for skin cancer, but he does have a positive history of actinic keratoses, or AKs, which are precancerous lesions. He presented with a brown spot on his right hand. He stated that it has been present for a while. The lesion does not bleed, is not tender, and it has not changed. And if you look to the right here, you can see that there's a photo of his lesion, and you can see that there's an irregular brown patch with areas of lighter and darker pigmentation on his right hand. So based on the clinical presentation and history, we came up with a list of differential diagnoses, including solar lentigo, melanoma, and macular seborrheic keratosis. And lentigos, as you can see on the left right here, they usually present as light or dark brown macules or thin plaques with clearly defined edges, and they're found on chronically sun-exposed sites like the hands, face, and lower leg. And the melanoma, as shown in the middle right here, these usually appear as an unusual looking freckle or mole, and melanoma lesions can have a variety of colors, including tan, dark brown, black, blue, or red, and they can sometimes even lack pigment or have areas of regression that are the color of normal skin color. Some other signs of melanoma include changes in size, irregular shape or color, inflammation, oozing, or changes in sensation at the site. And this is important because, as we know, missing a melanoma can be quite dangerous. And then lastly, we have a macular seborrheic keratosis, which is shown on the right over here. And these can have a variety of colors as well, including skin color, yellow, gray, light brown, dark brown, black, or mixed colors. And they're typically flat macules or raised papules or plaques with a smooth, waxy, or warty surface, as Dr. Buchanan previously mentioned. And they can appear on any areas of the skin except for the palms and the soles and mucosal membranes. And sometimes they can look as suspicious as a melanoma. So given this broad differential, we can use the dermoscopy to get a better idea of what we're dealing with. So this is our lesion under dermoscopy, and you can see that it looks quite different from the clinical photo that I showed earlier. And at first glance, it can be quite overwhelming with the many different features that we see with different colors, hairs, and different characteristics. But we can use the two-step algorithm for dermoscopy to diagnose the condition and rule out a melanoma. So again, this is the two-step algorithm. And the first step is to examine the lesion and determine whether it's melanocytic or non-melanocytic. And this is just a different schematic of the same two-step algorithm we have. And step one, or level one, is shown at the very top right here. And these show different characteristics of lesions of melanocytic origin. And if the criteria of level one are met, so if you have characteristics of level one, you can move on to step 2 to determine if the lesion is benign or malignant. But if your lesion does not have any signs of the characteristics in level 1, it can be deemed as non-melanocytic, and then you can look for different features for non-melanocytic lesions, such as the ones that Dr. Buchanan went over today. All right, so going back to our lesion on dermoscopy, we can go through that 2-step algorithm. And again, the first level step is to determine if the lesion is melanocytic. And to do this, you search for characteristics like pigment network that you can see on the top row over there, or globules, homogeneous blue or brown characteristics, and then some of these other characteristics we see on the bottom row. And then we can see that our lesion, it's hard to appreciate any of these characteristics. I don't see a pigment network, globules, or homogeneous pigmentation, so we can conclude that our lesion is likely non-melanocytic. So now that we have determined that our lesion is non-melanocytic, we can move on to step 2, which includes looking at the additional characteristics. So here you can look at level 2, level 3, level 4, level 5, level 6, and level 7, and so on, go through different features of non-melanocytic lesions so that we can determine whether it's a basal cell, a squamous cell, or seborrheic keratoses. Today for my presentation, we're going to focus on level 3 and level 4. Okay, so what patterns do we see? Here we can see that our lesion has some rosettes present in the lesion, and rosettes consist of 4 white dots arranged in a square resembling a 4-leaf clover, as you can see at the top right of the PowerPoint. And rosettes can be seen in botany, and they appear in flower-like arrangements of petals of similar sizes surrounding a central structure, like this photo. And you can see when you compare the 2 photos, they look very similar. And based on the algorithm, rosettes can be a feature of squamous cell carcinoma, but they can also be seen in different lesions such as actinic keratoses, chronic sun damage, and rarely in melanoma. So a study included 6,108 consecutive skin biopsies, and it found 63 biopsy cases that featured these rosettes. And they were found in the greatest percentages of squamous cell carcinomas, dermatofibromas, scars, and molluscum. But they are also found in more concerning lesions like a melanoma. But it was quite rare with only 2 cases, and it consisted of only 1.4% of all the melanoma cases. This shows that rosettes are not lesion specific, and they can actually be seen in various cutaneous lesions and inflammatory diseases. And this is helpful to us because since rosettes can help us with our differential, especially along with the clinical presentation and history, and we can lower our own suspicions of a more serious melanoma diagnosis since rosettes are quite rare in melanomas. And then here we can see some fingerprint-like structures. Fingerprint-like structures are typically tan or dark brown, and they look like these fine parallel lines and are typically seen in solar lentigos and seborrheic keratoses. So putting it all together on dermoscopy, we first saw a non-melanocytic lesion, and it had features of both rosettes and fingerprint-like structures. So we can change our differential diagnosis to reflect these dermatoscopic findings to pigmented AK, pigmented squamous cell carcinoma in situ, and lentigo with chronic sun damage. Melanoma was kept on our differential because clinically, when we looked at it, it looked a little suspicious and appeared a little disorganized on dermoscopy. But as we learned, rosettes are quite rare in melanoma, and there were no other dermatoscopic patterns consistent with melanoma. So we were much less worried, but we wanted to keep it on our list. And then with this solid differential, we thought a shave biopsy was important to determine the diagnosis, as management would also be very different depending on the diagnosis. So this is a photo of the biopsy, and the pathology report read slight epidermal hyperplasia with buds of heavily pigmented keratinocytes with rounded bases emanating from the epidermis, also known as that dirty sock pattern that Dr. Buchanan went over. And you can see the arrows are pointing to kind of like that darkly pigmented areas in the epidermis. And additionally, we saw some areas of bluish color in the dermis, which corresponds to solar elastosis, and this is common in the setting of chronic sun damage. So with these two clues on pathology, the dermatopathologist ultimately diagnosed it as a solar lentigo on a background of sun damaged skin. So that's the end of our case. We chose this case because it was a unique case of a solar lentigo that had rosettes on dermoscopy. Again, rosettes are more commonly seen in actinic keratoses and squamous cell carcinomas, but they can be present in a variety of lesions, including other skin cancers, benign lesions, inflammatory dermatosis, and even solar lentigos like our case. Additionally, our case was clinically concerning for a melanoma, but based on dermoscopy findings revealed rosettes and fingerprinting, so our differential diagnosis favored a keratinocyte carcinoma or another benign lesion over a melanoma. And lastly, we have a question for the ECHO team. Are there any further insights into the etiology or correlation of rosettes on dermoscopy?
So Dr. Buchanan asked me to show a few more images of rosettes. So if it's possible, if I can share my screen with you, I'll show some of those images.
That's great. We got a couple of minutes.
Okay. Let's see. Okay.
Well,
Now,
Okay, so as was discussed, rosette is actually derived from the natural shape of rosette in botany formed by leaves radiating out from the stem. And you can see with non-polarized dermoscopy, it has sort of what's been called a targetoid appearance. But with polarized dermoscopy, you see these beautiful rosettes. It's probably due to an optical effect of the polarized light and its interaction with adnexal openings that are either narrowed or filled with keratin. So it's really due to keratin, which is filling the follicular openings. Here you see rosettes with a squamous cell carcinoma in situ. The most important feature is not the rosette, but these vessels as red dots. In this instance, another example of a pigmented squamous cell carcinoma in situ, very often they overlap with pigmented actinic keratoses. In this instance, another squamous cell carcinoma in situ, here one sees these rosettes. A basal cell carcinoma occasionally can have rosettes. More importantly are these shiny structures, which Etsu mentioned before. We usually see these with superficial basal cell carcinomas. Melanoma rare, you saw there were only 2 cases in that article. We've only had 2 cases in about 30 years of a melanoma in rosettes. Like in plants like keratosis, any inflammatory process theoretically can have rosettes. And finally, a pigmented actinic keratosis with these beautiful rosettes.
thank you, Dr. Rabinovitz, and thank you again, Sally, for the case presentation. Any questions or thoughts from the participants? I know it's one of those things, the more we go through these things, for me, sometimes it becomes even more challenging to try and arrange in my head the things that matter most. It's helpful, I think, to be able to identify rosettes, not that it eliminates the possibility of melanoma, but that it reduces dramatically the likelihood that it could be, which could give you the opportunity to do a different kind of a management strategy, such as in this case where they did a shave biopsy instead of a wide local excision or another form of biopsy. So it gives you some reassurance. Any thoughts from any of the participants? Questions?
Just one further comment. When we see rosettes on the face with these fine red scaly areas, these are actinic keratoses. Squamous cell carcinomas have a different pattern. So when I see actinic keratoses on the face with rosettes, I treat these topically with one of the topical chemotherapeutic agents. So it is a very, very important clue, particularly on the face for these non-melanocytic neoplasms.
That's great. Thank you. Dr. Davis, did you have anything to contribute?
No, I would agree totally with Dr. Rabinovitz. And I think that actinic keratosis is one of the most common things that we see, and that these rosettes are just one more clue making us feel better about using topical therapy or freezing individual lesions.
Terrific. Thank you. All right. Well, we're going to wrap it up with that. I'm going to turn it back over to Rhea for closing comments.
okay. So I want to thank Dr. Patton for co-facilitating. I want to thank Dr. Buchanan for her presentation and Dr. Ajabo and Sally for great case presentations and everyone who participated in the discussion. So,
No. There is a question in the chat.
In the chat,
Oh.
we have a question.
okay, there is a question in the chat.
Dr. Buchanan, I was curious, so SKs are referred to as wisdom spots, but what is the earliest age that these are known to present?
Well, I'm almost 37 and I have one on my thigh. So I think, usually I was always taught after age 30, you can see them. So, I think you could probably see them in the late 20s as well. But again, you can reassure patients that they're benign.
Thank you.
You're welcome.
Okay,
Back to you, Rhea.
anyone wanting CME or CNE credit? We have the code here and the text number on the slide. It's posted in the chat and you will receive an email with the information afterwards as well. Message to the TeleDerm clinics, we'll periodically be sending you a brief survey to fill out after our TeleECHO sessions, and there's less than 5 minutes, so please do that. We need that for our records and for making these programs, presentations more improve and what you want and so forth. So our next session will be in 3 weeks, October 3rd, and Dr. Buchanan will speak on basal cell carcinoma. And we'll have one case presentation by John Hetzel, one of the medical students. And we are looking for a volunteer from the clinics to do a case presentation. So any of you providers from the clinics, if you are interested and have a nice case to present, please let me know. And Dr. Buchanan will be happy to help you with your presentation. So just let us know, emailing teledermatology@augusta.edu. So we would like to do that. Actually, I realized that next week we'll be celebrating our first consult that we received in the TeleDerm project. So we have been at doing this for the consult business. We've been doing that for a year now. So that's a nice milestone to meet. And I think that about wraps things up. Reminder to the TeleDerm team to stay on for a few minutes so we can have a debriefing. And I think now all the folks from the spoke clinics and all of our guests, you're free to sign off, and just thank you for being here and hope to see you all in 3 weeks.
Thanks, everyone.